psychiatry orientation. So for this video, we're going to be discussing kind of the patient's ability to know, when you ask them the date, the time, where they're at, who they are, what they're doing. And that way, we kind of know at a baseline what their orientation is. And that's why we say in the hospital, alert and oriented ×3. And the ×3 is time, place, and person. Okay. Do they know the time, like what day it is? Do they know where they're at? And do they know who they are, their name or something, about themselves? All right. So starting off, we'll go with Korsakoff syndrome. Korsakoff syndrome is, once again, it's going to be caused by vitamin B1 deficiency. It's going to be seen in chronic alcoholic usage. We've already discussed Korsakoff syndrome, but what they want you to know is that the mammillary bodies are usually atrophied. Okay, so that's going to be the main site in the brain that's going to be atrophied during Korsakoff syndrome. It's the mammillary bodies. All right. Next is dissociative disorders. So first we have depersonalization or derealization disorder. What you need to know about this is that it's just recurrent episodes of feeling detached from self or surrounding. Okay, so they have like outside of body experiences or outside of one's environment experiences. But the patient, what's important here is that the patient's still aware that sensations aren't real. Okay, so they have intact reality testing. So once again, they're not like in a psychosis where they're visualizing things that aren't there. They still are aware that sensations are not real. Compared to like hallucinations or psychosis, those patients do not know that these situations aren't real. They still think it's a part of reality. Whereas in depersonalization and derealization disorders, they still have an intact reality testing. So they are aware that sensations are not real. They are aware that the things that they're experiencing of like fuzziness and fogginess and the detachments and depersonalization and derealization, they realize that it's not real. Next is dissociative amnesia. Dissociative amnesia, what you need to know is that it's essentially after a traumatic or stressful episode that's so severe, they tend to forget personal information afterwards. Okay, so they have an inability to recall important personal information after a severely stressful or traumatic episode. Okay, and that's dissociative amnesia. All right. Next is going to be delirium. Delirium is probably the highest yield out of the orientation issues. Delirium is the waxing and waning level of consciousness that occurs in an acute onset. Waxing and waning is very, very important. They come in and out of delirium. The reason behind it being so important is because if you're comparing it to a patient who is ANO ×1, so they're alert and oriented to only like person, that's very hard to differentiate from delirium compared to like Alzheimer's disease, someone that's experiencing some form of dementia. The reason you know it's delirium is because it's waxing and waning. So these patients come in and out of episodes of, alertness and oriented natures. Okay, so they could be ANO ×3 1 hour, and the next hour they could be ANO ×1, or the next day they could be ANO ×1. And so it's waxing and waning levels of consciousness that occurs in an acute onset. So they could come into the hospital and they're ANO ×3 or ANO ×4 essentially is the thing that they say. So they're at their baseline, and then acutely they change. Then we get worried about delirium. Okay. Now, delirium is usually secondary to medications like psychoactive medications or over-the-counter drugs that can cross the CNS and cause delirium. But also, kind of one of the key things that they want you to know is that it usually is associated with patients that are just in the hospital. It's a hospital-associated type of disease. All right. And that's very key. Now, delirium is reversible. Unlike dementia, delirium is reversible. And what they want you to know is how can you help reverse it? Well, first, identify the medications. If there's no medications that's causing them to be delirious, then the next thing you need to do is orient them as much as possible. Now, how do you orient patients? Well, if a patient's in the hospital, think about hospital rooms. They're dark all the time. People get confused whether it's day or nighttime, and that leads to increased risk of delirium. So what you need to do, open the blinds throughout the day, close the blinds throughout night so they can get oriented back to time, right? Another thing that you can do, increase nocturnal sleep, help them sleep a little bit better. People get very uncomfortable when they're in the hospital. They're not sleeping in their own bed at home. They're very uncomfortable, so they have lack of sleep, which increases risk of delirium. Now, the last important thing that I would say about delirium is kind of how would you go about treating them? Well, we already discussed just the minor ways of treating them, stopping the medication that could cause it, orient the patient as much as possible to like their normal daily activities, giving them more sleep, not nighttime sleep, okay, keeping them awake during the day with opening the blinds and letting them sleep at night more. That's all going to be helpful. But if the patient is like crazy and losing their mind acutely and they're freaking out and they're attacking, the physicians and the nurses and the staff, what you could give them is antipsychotic, specifically haloperidol as needed. So whenever someone's like freaking out, they can give them haloperidol to calm them down. Okay. And they call it vitamin H because that's how often they use it in the hospital. Okay. Haloperidol is pretty much PRN as needed.